Discover how the Syn-One skin biopsy is transforming diagnostic accuracy for Parkinson's and related conditions, with insights from Dr. Jonathan Isaacson, lead investigator of its 3-year clinical utility study.
So historically, we didn't have good ways of identifying Parkinson's disease and Parkinson's related conditions outside of a clinical examination based on clinical symptoms. But many studies looked at how accurate a diagnosis was in the early disease course, typically within the first 5 years. And they found that really only 60% of the diagnoses made in the first 5 years is accurate. And typically it gets amended after interval examinations and after time has passed. In the atypical forms, many patients can carry the wrong diagnosis throughout their disease course. And even, as we study the brain and do autopsies on patients who unfortunately passed away from some of these conditions, the diagnosis can be wrong in a certain percentage of patients. Some studies looked at, almost 20% of patients had the wrong diagnosis in some of these atypical forms of Parkinson's. So over the last 15, 20 years, there's been more of a push to better understand how these conditions present and if there's ways to diagnose these conditions more accurately. The first diagnostic tool that came on the market in America was the DAT scan, where we can visualize dopamine transporters in the brain and see a diminishment of those dopamine transporters in the disease course of these conditions. And that can vary depending on what the etiology of these conditions are. That was helpful, but the problem is with DAT scan is that any type of condition that causes Parkinsonism will have a diminishment in the dopamine transporters in the brain. So conditions like Lewy body dementia, Parkinson's, multiple systems atrophy, PSP all have lower dopamine in the brain. But this scan could differentiate patients who may have been on medications that block dopamine or have essential tremor that looks a lot like Parkinson's. So in that way, it can be beneficial, but it didn't help us differentiate these two conditions or these multiple different types of conditions. The skin biopsy over the last couple of years has been on the marketplace to help better diagnose these conditions and better understand the progression of symptoms over time. What the skin biopsy does is it looks for phosphorylated alpha-synuclein in the nerve fibers of the skin. So it's with a simple skin biopsy procedure in 3 different locations, looking for synuclein deposition or that abnormal protein that we see in the Lewy bodies in the brain that we can identify in the periphery of the skin. So it can help us better understand what disease course each individual patient has. Outside of that, there's hope that it can help identify patients even in the prodromal period if they carry synuclein prior to even having presentation of their symptoms. And then maybe it can be used in the research context to better understand how synuclein deposition takes place and how it advances as the disease advances. They've done studies looking at if we can differentiate these diseases based on not just location of the synuclein deposition, but on the quantity of the deposition and in the kind of pattern that the synuclein is deposited in the 3 locations. So for example, we know that Parkinson's disease has a higher concentration of synuclein deposition in the cervical region, in the posterior cervical behind the neck region, where we take the synuclein skin biopsy. In conditions like MSA, it's about equal in all 3 locations, and there's not that propensity to have more in the posterior cervical region with multiple systems atrophy. Patients deserve to have the right diagnosis of their condition so they have the right treatment and they're better able to be on the right medications or the right clinical trial, or to better understand the disease course and pathophysiology, or what to expect in the future and life planning and things like this. We don't believe in just having suspicion and tracking things over time. Just like you would have, if you break your arm, you would get an x-ray. Just like if you have a stroke, you get an MRI. In these neurodegenerative conditions, we should have a thorough workup to better understand and diagnose these conditions. We know that if you treat one patient with Parkinson's disease, you're treating one patient with Parkinson's disease. It's such a heterogeneous disease course, and each patient is so different that we really have to pinpoint and have precision medicine where we're understanding each patient individually and better treating them.
We hope you enjoyed this video. To access a free Mastering Brain Health course led by Dr. Richard Isaacson, visit ind.org/learn. And to directly contribute to IND's research efforts, visit ind.org/donate.